We shall now go on to our next set of topic, fluorescein angiography versus ICG in diagnosis of uveitis. And we have Dr. Anamika Patel, who is a consultant vitreoretinal diseases and uvea and immunology from Visakhapatnam. And countering her would be Dr. Anu, who's again a consultant ophthalmologist, vitreoretinal diseases from LV Prasad Bhubaneswar. So let's hear both of them. Young blood, so I think there's going to be even greater fire here.
Thanks, Dr. Chitra, and the Aios ARC team for giving us the opportunity to speak. And this happens to be my favorite topic, the fluorescein in the diagnosis of uveitis. So let's get started. So I have two questions for my very dear friend Anup here. That Anup, do you really feel that you need ICG in making a diagnosis of uveitis? That was question one. And second question is, do you think you have any kind of an established protocol in the treatment and the follow-up of your uveitis patients based solely on the ICG? You keep on thinking about it, and let me quote Carl Herbert's paper on fluorescein and indocyanine grain angiography for uveitis. And I think everybody would agree with me, it's kind of a no-brainer schematic diagram where it beautifully describes how fluorescein gives the information on almost everything, starting from the NVE to retina to retinal vessel, choroidal neovascularization, NVD, subretinal fluid, all of us can read that, and how ICG is solely kind of only near the choroid. So I think I've made my case, but I still have some more time. So let's get started. So for any person who contests that why ICG is better than FFA, let me give all of you here who have that thought in their mind the 5 pointers. First is kind of theoretical and the rest all are clinical. So if you look at the molecule, the fluorescein sodium as we know it, it's a micromolecular in behavior because it's 80% bound in compared to ICG, which is a macromolecule. Now, fluorescein sodium molecule, it entirely predominates the retinal circulation, and that's the reason why you see leakages kind of everywhere. But if you feel that you do not get any info on choroids, so that thought is not correct, because in the early frames, up till the 60-second, you still get some information on the choriocapillaris. So that was a theoretical point, and rest all other clinical points. So if you have a suspicion of any subtle disease activity, this leakage is seen better on FFA. If you feel that there is the presence of this slight vasculitis and you have a doubt of neovascularization, as you can see how beautifully you can pick up the neovascularization better on FFA. Anup, I'm sure you must have done some lasers for your retinal vasculitis patients when they have come up with the neovascularization. And I hope you have done FFA rather than ICG to appreciate the CNP and to do the laser-guided photocoagulation. Now, I'm sure all of us know about the mutes, and the beautiful wreath is picked up only on FFA. And the other point about this beautiful pinpoint hypofluorescence, which you get to see both in the VKH and the posterior scleritis, is seen best on FFA. This is the last point which about the treatment response. So this is my patient, a pediatric patient, I would say, who had presented with this picture. And here you can see that how she had the hot disc, cystoid macular edema, and this beautiful furring all over, and how over a period of time, everything got resolved. So this was done on FFA, picked up on FFA and not on ICG. Point being the disc leak, fawning pattern, and CME, they all are better appreciated on FFA. So this guides me on my treatment and to recognize what I'm dealing with. So Anup, if you are still thinking that I see hypos on my ICG, let me show you this comparative image here, that this FFA shows you your hypos and this ICG also shows you the hypo. Maybe you can just count maybe 3 or 4 extra hypos. But having said that, do you feel that you are going to change your diagnosis or the treatment approach to the patients when you see something like this only on FFA? So, well, FFA is time tested. It's a gold standard investigation. It helps you in complementing your clinical suspicion. And I feel, and I urge this, the uveitis or the people here, that I'm sure I can assure you that the absence of ICG is not going to create a gaping hole in anybody's uveitis practice. So Anu, I rest my case here. Over to you. Thank you.
Thank you.